are now free under Medicare. This includes vaccines like the shingles vaccine, which many of us need and should have. Used to cost somewhere between $175 and $200 to get that vaccine. It's free now. And the process of limiting price increases year over year by forcing the companies that increase their prices faster than the rate of inflation to pay rebates, that process is now engaged. And we have a way that we can pull back the reins on price increases, as many of us, too many of us know and have experienced. The drug companies have raised prices at will, using the people of the United States and taxpayers as a piggy bank, because we granted them the power to raise prices as much as they wanted. Now we have a way to constrain prices by forcing rebates to be paid to Medicare if they raise prices faster than the rate of inflation. And importantly, the measure of inflation isn't just price increases under Medicare, it's price increases across the entire healthcare economy. And so it puts a little bit of a brake on them in the private sector price increases as well, because how much they increase prices in the private sector and how much they increase prices in the public sector will both be taken into consideration when deciding if they have hiked prices and exceeded the rate of inflation. So that's what's taken effect in this year. Now, there's much more good stuff to come under the Inflation Reduction Act. And I'll take a minute just to mention some of them. Next year, for those of us who are unfortunate enough to be on very expensive drugs to stay alive, there's going to be a cap on what we pay out of pocket. Right, I have an incurable blood cancer, and prescription drugs are keeping me alive, literally. Right now, my doctors have me on a 4-drug combination that carries a list price of more than $900,000. Just one of those drugs under Medicare Part D, the prescription drug benefit, costs me more than $16,000 a year out of pocket. Starting next year, that's going to be capped at a level probably in the range of $3,000 to $5,000. I'll no longer pay after I hit a certain level. So for those of us on very expensive drugs, we're going to get some relief from our high out-of-pockets next year. And that affects all drugs for people on Medicare. And we're going to expand the eligibility for low-income subsidies for the prescription drug benefit, which will make access to the prescription drug benefit program less expensive for people. And that's a big deal. In 2025, all out-of-pockets will be capped under the Medicare prescription drug benefit at no more than $2,000 annually. Right now, there's no limit. That's how I get stuck paying more than $16,000 a year. And then in 2026 and after, we will have been negotiating, but negotiated prices will begin to take effect in 2026. And it'll be 10 Medicare, those 10 of the most expensive drugs for Medicare the first year, 15 more the next year, 15 more the year after that, 20 more the year after that. So by the time we get to the end of the decade, we'll be negotiating over 60 of the costliest drugs for Medicare, if we don't add to that number by doing more, which we intend to do. So that's kind of a big, long overview. I hope I didn't talk too long.
So tell us, when this bill got passed, there was a movement in the Senate to also cap insulin copays for everybody, not just people on Medicare, but what happened?
There was. And the way the Inflation Reduction Act, with all of its provisions, its climate provisions, its drug price provisions, the other provisions it included, the only way that that could pass the Senate, given that there were only 50 votes, there was not one Republican vote to be found, unfortunately, to pass that bill. Since there were only 50 votes, it had to be done under an arcane procedure called reconciliation. If you use reconciliation, it has to have a direct impact on the federal budget, or it can't be done through reconciliation. So the umpire of those decisions, whether something can be done under reconciliation or whether it can't, is the parliamentarian, the Senate parliamentarian. And the Senate parliamentarian took that provision to cap out-of-pockets for insulin monthly at $35 out of the reconciliation package. It couldn't move that way. So there was a bipartisan bill brought forward by Senators Shaheen and Collins that would have capped out-of-pockets for insulin at $35 a month across the whole economy. And it was brought to the Senate floor, that bill, and it was defeated. It needed 60 votes to pass. If you don't use reconciliation, you have to have 60 votes to pass it. It got 7 Republican votes, 3 short of the 60 necessary to enact that bill into law. But we came this close. And by the way, we ain't giving up. There are a lot of people, not just people who are dependent on insulin, who need affordable drugs and affordable co-payments. And, people who have autoimmune diseases, people with cystic fibrosis, people with cancer like myself. There are a host of conditions that require multiple sclerosis, I should be sure to mention, that require extremely expensive drugs. And all of those drugs, along with insulin, need to be made affordable. While we took incredible steps forward last year with the Inflation Reduction Act, there's much more to do, and we're working on doing it.
And can you talk a little bit what all we could have happen next year? What should people be calling their senators and their representative about? What is it that patients are asking for this year?
We have 4 priorities at Patients for Affordable Drugs. We're little, we're not a big organization. And so we try to be very focused on what we do. The first priority we have this year is making sure that the Inflation Reduction Act provisions to lower drug prices are implemented effectively for patients. There is a whole bunch of work associated with making and implementing the policy. HHS has hired, I think, in the neighborhood of 100 people to implement the provisions of the Inflation Reduction Act. There's a lot of work to do, and we intend to support enthusiastically and energetically the implementation to make sure it's done in a manner that works for patients. For example, the $2,000 a year out-of-pocket cap also included a provision to smooth it out and equalize the payments every month. So patients didn't get hit with $2,000 for an expensive drug like mine in January and then didn't have any out-of-pocket for the next 11 months. That's hard for a lot of people to absorb $2,000 in 1 month. And so we want to make sure that the provisions are enacted in a way or implemented in a way that looks after the needs of patients and that we get the most out of what we passed last year. That's the first thing we're focused on. The second thing is it's time for us to look more closely at what PBMs are and are not doing. PBMs are pharmacy benefit managers. they're the people who run your prescription drug insurance programs. And they move more than $300 billion worth of drugs through the system every year, but it's all transparent. They're a black box. We don't know if what they do really is in the interests of patients, whether it's to get the patient the best possible drug or to get the patient the least expensive drug among equally effective options. And so there's a big investigation underway through the FTC looking at how PBMs are conducting their business. There's also legislation, bipartisan legislation in Congress to address some of the issues with PBMs. Third, we are working to stop abuse of the patent system. Right now, brand drug companies abuse our patent system and use it not to reward innovation, but instead to maintain monopolies for old drugs over a long period of time, much longer than intended under law. And so we're working with several groups on patent reform. And there is an initiative that was kicked off by President Biden calling on the US Patent and Trademark Office to work with the FDA to do a better job to make sure that patents are not being abused to hurt consumers instead of help consumers. And then finally, we are very concerned about the coming of very, very expensive cell and gene therapies. Right now, there are almost 400 at least cell and gene therapies in development. These are remarkable drugs, many of them. Many may be cures for certain conditions. And they will change people's lives. But the most recent gene therapy approved by the FDA a few weeks ago is priced at $3.5 million. And what pharma wants to talk about is mortgages for people to have to take out to pay for these drugs. Right now, because all they care about is how do we get our money, not what is the fair price for the drug. So we are focused on how do we develop a system that allows us to have a process to set an appropriate price for the drug that not only rewards real innovation, but that ensures affordability and accessibility, that balances out private profit with public health. And there's much work to do in this area. It hasn't hit us hard yet because most of these new cell and gene therapies are only for conditions that affect a few thousand people, like the $3.5 million drug. There are roughly 6,000 people. But there's probably a cure for sickle cell, a gene therapy for sickle cell, that affects 100,000 people in this country. And when we hit one of these remarkable new treatments that can help that many people, we have to have a way to arrive at an appropriate price. It can't just be letting multinational drug corporations say, this is what we're going to charge, and you have to find a way to pay it. That can't be. We can't do that anymore. And I believe that the coming of these new treatments will force us to address this issue, and it's our fourth priority for the year.
Well, thank you so much, David. And thank you, everybody that joined us today. Be sure to find David and Patients for Affordable Drugs if you're interested in fighting for affordable drugs for patients. And please, everyone, keep calling and texting in your healthcare and health insurance questions, and we'll answer them in future episodes. This is Care Talk.